Life sure gets busy, doesn't it? Well, we understand. With all the certifications you have, finding the right kind of continuing education that fits your schedule can be a real challenge. That's where the FlightBridgeED Podcast subscription comes in. For less than $5 a month, the FlightBridgeED Podcast subscription gives you top-notch accredited CE while you listen. Visit FlightBridgeED.com for more information or to sign up today. The FlightBridgeED Podcast subscription. Another way we're being your partner in discovery.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today we're going to do a Nightmare Series case, and this is going to be a cardiac catastrophe. So let's get started. We have a 56-year-old male patient that had a ground level fall per family. This gentleman has some mental disability. So when you get on scene, you find him sitting in a bedroom against a bed. He has a normal appearance, GCS of 15. He is able to answer questions, is able to tell you who he is, what time of day it is, but you do notice he has a very flat affect. His main complaint is left knee pain. You don't notice any deformities, any rotation. He does have good movement, good pulses. So you start working this patient up. This is one of those types of calls where it easily could lead to a refusal just based on the initial impression and how you find the patient. The family is on scene as well because this patient is still living with parents at the age of 56 due to his mental disability. And they state that this is very, very normal for him. They state that it seemed that he actually had a neurosyncopal episode, didn't actually go all the way out, but kind of got weak and kind of dropped to the ground. Was never completely unresponsive, was able to respond, and just was a little bit drowsy per mom and dad. Current vitals, when you check them, blood pressure 129/76. He's got a heart rate of 89, respiratory rate of 16. You listen to his lung sounds, and his lung sounds are equal. You don't hear anything at all in any of the fields. So what do we do now? Well, obviously, a neurosyncopal episode, this patient is 56 years old. He doesn't really have any history per se, per the parents. So let's do a 12 lead. So we do a 12 lead and we notice a few things. Number one, normal sinus rhythm. He has P waves. He's got good QRSs. He doesn't have any depression throughout. He's in normal axis. And you note, though, that he has some very deep inverted T waves in the precordial, specifically V2 and V3, and appears to have a biphasic T wave in V5 and possibly V6. This patient is not complaining of any chest pain. He says he feels okay. Again, very flat affect, doesn't seem to respond appropriate to you as a normal patient, but per family, this is very, very normal. So what do we do? Again, very, very easy to say, hey, this patient has a normal 12 lead, even though we never want to use a 12 lead to rule out any type of MI, but he's got a good blood pressure, he's got a good pulse, he's got a good respiratory rate. There's nothing leading you to that this patient is sick. Skin color and temperature is normal. His leg appears normal. He's actually able to get up and bear weight. So what do we do? This is where gut instinct comes into play. This is where you just sometimes have to go with what your gut is telling you. And this call was one of those calls for me where I immediately had this gut instinct. And I remember talking this over with my partner that, he felt like this patient easily could just stay home, didn't need to be transported. I just had this gut feeling. We were about 10 minutes from the hospital. I thought, you know what, let's just go. Let's take the patient in. A neurosyncopal episode. There's really no reason why the patient isn't sick. There's no other, types of reasons that we could ascertain based on the history and how the patient was presenting. So we load this patient up. I jumped in the back of the ambulance, and we start driving out of the driveway. As I'm setting up an IV, I've already got the cardiac monitor in place. Obviously, we did a 12 lead. So all that is done. Blood pressure cuff is on, and I'm getting everything out for the IV. And I start noticing, and I'm talking to him, I start noticing that he is having a difficult time breathing. His respiratory rate has definitely increased. He's starting to be a little bit labored, and I'm starting to notice and hear audible changes in his breath cycle. Within a few seconds, I start audibly hearing fluid, and then he starts almost throwing up, or what appeared to be throwing up. But I realized very, very quickly that he was actually, this was CHF. This was copious amounts of fluid that is coming out of his mouth. And so he very, very quickly decompensated, went into respiratory arrest. For this podcast, I'm not really going to get into the airway management side of things. Obviously, we managed his airway. We intubated him. We did another 12 lead. And at this point, the 12 lead showed precordial, so we'll say V1 through V6, and 1 in AVL, tombstone ST elevation. So this patient had a massive LAD infarct, ended up going into CHF. We managed his airway. We got him, obviously, emergency traffic to a cath lab where he did survive, and we ended up following up with him. He had mitral valve replacement. So what happened with this patient? We have to understand that the heart, obviously, we have 4 chambers, 2 atria, 2 ventricles. We have 4 valves. We have our tricuspid and mitral valve. Those valves work opening and closing together because those are the entrance points from the atria into the ventricles. We have our pulmonic and our aortic valves that open and close at the same time as well. Those open and close during diastole. So our tricuspid and mitral valve open during that systolic phase, obviously letting blood go from the atrias to the ventricles. The pulmonic and aortic valves open and close during diastole, and those are exit points out of the ventricles. So obviously the pulmonic lets blood go through the pulmonary artery into the lungs for oxygenation, and aortic goes into the aorta, out through our body to where we have oxygenation throughout our body. So when we look at why this patient decompensated, number one, we have to understand that we have papillary muscles. And these papillary muscles, although this is a more uncommon presentation, this can be catastrophic if you have a papillary muscle rupture. So these papillary muscles essentially are to not allow for prolapse. They're so that the blood doesn't back through those valves into the atrias. And if these papillary muscles actually rupture, what you're going to have is obviously prolapse, severe regurgitation, and overall catastrophic CHF very, very rapidly. So why did this happen? I think back at this call all the time because this is a great example and a good teaching point for a lot of reasons. Number one, we never ever do a 12 lead to rule out an MI. We only do a 12 lead to identify ST elevation. So that is number one, right? We never can rule out an MI. We could be having a non-ST elevation MI. We may be having some type of other presentation that it maybe isn't being picked up yet by that 12 lead. We always want to get them to a definitive facility where they can run labs, run a troponin, etc. But we have to always use that high index of suspicion. This was a time where we were running 12 to 15 calls every shift. This was in the middle of the night. This was a very, very easy call where we could have just said, hey, this patient has isolated left leg pain. You know, we've went through all of our differentials. The patient seems and appears to be very stable. We could have easily got a refusal from the family, and the family was actually on board for that. We actually had to kind of push to say, hey, let's take this patient in to get him checked out. When we look at other telltale signs, when you see a 12 lead, and even though we don't see the classic ischemic changes. We have to understand, we've learned a lot through the years that we have these other factors. We're going to talk about AVR, but one of those factors is called Wellen syndrome. And Wellen syndrome is basically characterized as a classic T wave inversion or a biphasic T wave seen in those precordial leads. So usually the deep inverted T wave is going to be seen in V2, V3, and maybe into V4, and then your biphasic is going to be seen in V5 and V6. There's two actually forms of Wellen syndrome. The majority, or about 75% of these patients, have type 1 Wellen syndrome, and that is going to be that deep inverted T wave. And I will put a copy of a couple different 12 leads in the show notes. Again, remember the show notes are going to be on the website. You have to go to the current podcast, click on that podcast, scroll down to show notes, and you can download and look at those 12 leads. But Wellen syndrome is very, very important to know. Number one, this is significant because the patient has to be pain-free to see that Wellen syndrome. So this patient was not complaining of any chest pain. Again, because of his mental disability, he was very, very, had a very poor affect, I should say, wasn't a good historian, definitely couldn't explain how he was feeling. Unknown if he had chest pain prior. So maybe that's when he had the syncopal episode, and maybe he did have some chest pain. And so this is very significant. If you have the appearance of Wellen syndrome, again, deep inverted T waves in V2, V3, maybe into V4, and then you'll have those biphasic T waves, which is a type 2 Wellen syndrome, only encompasses a small portion, and usually the biphasic T waves are going to be seen V2, V3 as well. So you can have extension into V5 and V6, but usually the V2, V3, those classic anterior leads are going to be the most common. So I would definitely use a high index of suspicion. If you're seeing any deep inverted T waves in V2, V3, V4, and up into V5, you see any biphasic T waves, even though the majority are going to be in V2, V3. There are examples. I've seen many 12 leads where this is definitely apparent in V5 and V6. So really any precordial leads, if you see those patterns, that should be a very high index of suspicion. So we always say have a very low threshold for those patients. Cardiologist, if they identify any Wellen syndrome, these patients will never ever be put on a stress test. They're never going to be they're always going to probably go to an interventional cardiologist very rapidly, because usually you're about a week, maximum 1 week, from having a big high tombstone ST elevation MI. Wellen syndrome always means you have a significant LAD disease, and so you have this stenotic vessel. It could be that entire left main, and remember that left main, you have that first branch, that circumflex branch, you have the diagonal and marginal arteries that come off the circumflex and the LAD as well, and so that entire left main, LAD and circ, all of those feed that entire left side, the lateral walls, the anterior walls, or the anterior wall. So we have to always think these are the worst MIs we can have. Now, why did this mitral valve blow out? Well, because if you have an anterior wall MI, that's exactly what we're talking about. That is right where those papillary muscles intersect, and you can actually infarct and cause them to not work properly. You have then a valvular prolapse. You're going to have that valve not work properly, and you're going to definitely have regurgitation, and that's exactly what happened. And so this has happened to me twice in my career. This one was obviously the most dramatic, and when I say you could actually hear the fluid kind of rising to the top, and it just started flowing out, and it was copious, like it would not stop. For having a patient sit in front of me, talk to me, answer questions, and decompensate literally within 30 seconds like this was very, very dramatic. When we look at Wellen syndrome, remember, pain-free. This always means significant LAD disease. This means you have a stenotic or a narrowed vessel, so insufficient vessel. We always need to have a low threshold, and always ask yourselves, did this patient recently have a chest pain that has resolved? So that is also very, very key to Wellen syndrome. So what do we do? Well, obviously this patient, if you identify a patient that is a potential Wellen syndrome patient, you get on scene, you have a patient that had chest pain, now it's resolved, you see these inverted T waves or these biphasic T waves in the precordial leads like this patient needs to go to a interventional cardiologist. It may not be a STEMI criteria, but you always have to use, again, that low threshold and think about getting them to a facility that can handle this. This is very standard. We should all know Wellen syndrome. And again, I will put 12 leads in the show notes for examples. This patient ended up doing well. This patient did have a good outcome. They did have to replace that mitral valve. Before we leave, remember we also have other criteria that is not classic. And I think the other big one that I did a podcast on about 4 years ago was AVR. And remember, in the presence of ST elevation in AVR of at least 1 millimeter, if that elevation is greater than elevation seen in V1, so essentially what we're talking about is you have ST elevation in AVR of 1 millimeter, you either have ST elevation in V1 of less than 1 millimeter or 0 ST elevation. So essentially, if AVR is elevated. Now remember, AVR should always have a primary QS segment. We should never have a primary R wave. We should always look at AVR from the perspective of limb lead placement, making sure our limb leads are correct. And if that is the case, and we're supraventricular in origin, we should always have a primary QS wave. So if you have an ST elevation in AVR, and you have anterior leads that are showing depression, that is very, very suggestive. Been proven by many different research articles that this is suggestive of a high left main occlusion, or what they say is a 3-vessel disease process. So again, you're catching the big left-sided MI before it happens. It could be days, could be weeks. I know I've taken a few of these in. These have both been taken in as emergent casts, and they've been taken right to the cath lab. And so these are things in your area. If you're not doing these things, this is more evidence-based practice stuff. It's not the classic, rigid protocol where we just look at the lateral, the inferior, the anterior, etc. This is using the newest research, and a lot of this stuff is not brand new. This has been around for quite a while. Scarbosa criteria is another one. Scarbosa criteria has been around since 1997, and you see it used in some areas and not used in others. So, you have to take this stuff, and it doesn't mean that you can't learn this stuff. It doesn't mean that you can't introduce this stuff. Go to your cath lab, go to your cardiologist, build a relationship with them, ask them how you want to handle this. And again, it's all about doing the best thing for the patient, and you're responsible for doing that. So hopefully this case sheds some light on Wellen syndrome if this is new to you. If not, this was a case that I'll never forget. And, always remember, use that gut instinct and always make sure you're doing the right thing for the patient. And if you're not able to get a good history, you're not able to, answer those questions definitively, even though everything looks or appears to be normal, you never know. It could be a ticking time bomb, and I think this was a lesson for me. So until next time, again, if you have any questions, any cases, please email me at eric.bauer@FlightBridgeED.com. We so thank you for the support of FlightBridgeED, for continually listening to our podcast. I know on behalf of my team and my wife, we're so thankful. So we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.